Welcome to the first TRI Innovation series in the seminar series that will present most recent and exciting research from the pilot program, KL2s, and other innovative investigators who have been sponsored in one way or another by the TRI. Our topic for today is innovation in opioid and pain management research, a highly clinically relevant topic and specifically one which qualifies for the opioid CME requirement for the Arkansas State Board.
So the objectives of the course are to discuss new research on opioid addiction and pain management strategies and apply the presented research findings to your own research and clinical practices. Disclosures that we have, Dr. Mock, who is on our planning committee, he has a consulting fee with Nature's Bounty. Dr. Gorey has consulting fees with Abbott Laboratories and Stratus Medical, and Dr. McCool has contracted research with Genentech and Roche. So we have 6 presenters tonight, so we have a good variety of presentations, and we are going to start with Dr. Jonathan Gorey, who his project with us was a video-based patient-focused opioid education in the perioperative period, a feasibility study.
Thank you, Nia. I very much appreciate the opportunity to present this research that I've been working on for the past year. I'd also like to thank all of you in TRI, you, Nia, and all of you for helping to mentor me and support me in this research project. My name is Jonathan Gorey. I'm an associate professor in the Department of Anesthesiology. I'm the director of the Chronic Pain Division and the program director for the Chronic Pain Medicine Fellowship. And today I'm going to present video-based patient-focused opioid education in the perioperative period. Of course, I got my pilot funding from TRI, and so I'm very appreciative of their support. A couple of disclosures for me. So I teach a couple of courses for trainees about some interventional pain therapies, but none pertinent to this talk. Willing to answer any questions about that. Here's my outline. I'm going to talk about the background and purpose of this study, the methods, the results. I'll talk about our conclusions and then our future plans with both this novel tool that we created and also how we plan to disseminate the research. So I'm going to start with the background. And really, I think we've done a great job of combating the use of opioids for chronic pain, both here at UAMS, but also nationally. This started with the CDC guidelines, which were published in 2017, 12 guidelines that were focused on chronic pain prescribing, but only one of those guidelines actually focused on acute pain prescribing. And we all know that, honestly, the use of opioids for the treatment of acute pain is really the gateway to chronic opioid use and the development of opioid use disorder. And there have been a few studies that have looked at the risk of developing chronic opioid use after an acute pain event. But one that I quoted was from someone on this call, actually from Dr. Martin. And it really looked at that 10% of opioid naive patients who are prescribed a 7-day course of opioids often continue opioids at 1 year. And we really also don't do a good job of educating our patients with the risk, benefits, proper storage, and proper disposal of opioids upon prescribing, especially after an acute pain event. Patients are often given a bottle of pills. They may get a couple of sentences in the recovery room from either a nurse or a provider. Patients are often coming out of anesthesia, so they may not necessarily remember what's being told at that time. And patients are kind of left to use these dangerous medications in their home without much guidance or much instruction from a physician outside of the things that are printed on the pill bottle. The last thing is most of the education that is provided is given via handouts. And handout education is really poorly internalized by patients, and that's been shown in the literature multiple times. And so what we did was we examined the feasibility of a novel video-based opioid education tool that we based off a CDC document called Opioids, What You Need to Know After Surgery for opioid naive patients during the perioperative period. Our outcomes, we looked at 90-day postoperative opioid use using the Arkansas Prescription Drug Monitoring Program. And what we really looked at was 90 to 100, the amount of opioid prescriptions that patients received 90 to 150 days after their operative event. We also looked at self-assessed knowledge acquisition at postoperative day 7, which was obtained from patients via phone call. We looked at patient satisfaction, and we asked patients about their opioid use at postoperative day 7, 30, and 90. So for our methods, this was a prospective 2-arm randomized controlled pilot study. All patients were recruited between March 2019 and March 2020. We had an N of 120 patients who we consented. All of our patients were self-reported as opioid naive for at least 30 days prior to an ambulatory surgery event. That means a surgery event in which they were admitted to the hospital the morning of their surgery with a plan for them to be discharged the same day of their surgery with opioids for postoperative pain control. We called all potential patients 1 day prior to their admission and screened them to make sure they met inclusion and exclusion criteria. We also spoke to the anesthesiologist the morning of the surgery to ensure that the patient was planned to need prescriptions for postoperative pain control. Patients were randomized to one of 2 arms. One was our control arm, which is perioperative education by our surgical team. The second is perioperative education by the surgical team, plus the inclusion of a preoperative video-based education novel tool, which we created. The intervention arm was shown this tool within 2 hours of their operative event. Most patients at UAMS are asked to come for surgery about 2.5 hours prior to their surgical schedule. During that time, there are multiple providers and multiple medical professionals that end up talking to patients, but we actually were able to find a small bit of time where we were able to use a tablet device to show patients this video, which went over risk, benefits, safe usage, safe disposal of opioids during their perioperative course. All patients were called on post-op day 7, 30, and 90, and we also obtained de-identified prescription data through the Arkansas Prescription Monitoring Database, which was provided by the Department of Health. And I don't have a lot of time, but I wanted to show a small snippet of the video so you could understand what we were doing.
After your surgery, when you are ready to go home, your surgeon will give you a prescription for pain medicine. For your severe pain, your surgeon will probably prescribe you an opioid. Examples of opioids are hydrocodone, oxycodone, morphine, hydromorphone, codeine, Lortab, and Percocet. These medicines can help you with your pain when you take them for a short period of time. But they also have side effects and serious risks, like addiction or overdose. These risks are highest when you take opioids for a long time or at high doses. If you take opioids for longer than 6 days after your surgery, there's a chance you will still be using them in a year. This happens to 1 or 2 out of every 10 patients.
That just kind of gives you a small idea of what the video showed. Later on in the video, we talk about safe usage. We talk about alternative therapy, including Tylenol, ibuprofen. We also talk about safe storage and disposal of opioids to prevent diversion from family members. And so going into our results, this is our table 1. We consented 110 patients. We had 7 patients who were not included in our analysis for 2 reasons. One reason is we had 3 patients where their surgery was actually canceled once they reached the operating room after being consented. And we had 4 patients who had complications during their surgery, which required operative admission, which meant that they no longer met criteria. Our primary outcome was the dispense of opioids in 90 to 150 days after consent for the study. In our no video group, for which we had 52 patients, we had 12 patients who received opioids during that time period. In our video group, we had 5. Our odds ratio of receiving opioids after viewing this video compared to patients, compared to our controls was 0.362, but the confidence intervals did cross 1. This is a busy slide, but it really shows all of the questions that we asked patients. I wanted to call your attention to one particular question, and that is we asked patients to rate their knowledge of opioids after surgery. In the no video group, patients rated their knowledge of opioids after surgery at 8.3. In the video group, they rated their knowledge of opioids at 9.3, which was significant. And so the conclusion of our study is video-based opioid education can be implemented during the perioperative period. I think this was an outstanding pilot because it really showed, one of the questions that we had was whether there would be ample time to provide this information to patients, and we found that there was. I think our second question was whether patients would receive this information well. And patients generally did enjoy receiving this information at this time. We did find that patients rated their knowledge of opioids higher after video-based opioid education. And we found a trend toward decreased long-term opioid use after 90 days, which I think merits a longer randomized or a higher powered randomized control trial. Our plans for future dissemination of this work. We do have a poster presentation that is planned to the American Society of Regional Anesthesia and Pain Medicine this fall, actually in November. And we have just finished our manuscript, which we will submit in the next couple of weeks to the Journal of Pain Medicine. And as for future research, I have been honored to be chosen as an implementation science scholar. And I am looking at the use of, I'm also looking at a project that is very similar. How can we decrease short-term opioid use after a surgical intervention? The average post-surgical prescription written at UAMS is for 7 days. Our goal is to decrease that down to 5 days to decrease the risk of long-term postoperative opioid use. As a part of the larger strategy that we're implementing, most of that strategy is focused toward the provider, but we also feel that patient education and understanding the importance of decreasing the amount of opioids that they will be prescribed is key. And so this video, we will be a part of that implementation strategy that will be rolled out at UAMS in the next month. With that, I also want to give some thank yous. First, of course, to TRI, but also to some of my research mentors, Brooks Gentry, Jill Meyer, and Kane Pryor, who's at Cornell, who was the first person that I did research with, our research assistant, and also my collaborators, Corey Hayes, Michael Couture, Lauren Byers, and Nick Zoller. And with that, I appreciate your attention, and I'm willing to answer any questions.
So Jonathan, congratulations on a great study. I'm really pleased to see how that turned out. And I think it's a great use of that preoperative time to do some good educational work. And I love the video format. I'm wondering though, did they have any materials to take home with them that they could refer to if they had questions along the way? I'm not sure what the usual follow-up process is for people who have questions like after they've been discharged from the same day surgery.
Sure, I think that is an outstanding question. And the honest answer is it's very variable and it's surgeon dependent. Some surgeons have, and part of it's because different surgeons use different opioid sparing modalities postoperatively. Some patients get regional blockade. Some patients are allowed to use NSAIDs where some aren't. Some are allowed to use Tylenol. So it's been challenging to create something that's standardized for all services to provide across hospital wide. And so I know that some of our colleagues, and we really looked at 3 different types of surgeries, and they were evenly distributed between our randomized groups, but orthopedics, breast surgery, and ENT. The orthopedics group does have a standardized handout that they give to most of our patients. The other 2 groups do not. And so there was nothing that was handed to these patients that really reinforced the knowledge that we gave them other than the video itself.
So I have a question too. Are you done, Carolyn? Did you have another question?
Oh, I'm done. Thanks, Allison.
Oh, okay.
Thanks, Jonathan.
So I was curious about your definition of opioid naive. It appeared to be a 30-day abstinence, not necessarily naive. Could you kind of clarify that, and how similar or different were the groups based on that criterion?
Yeah, no, thank you for that question. So we really used patient feedback to ensure that patients were at least were what we would say opioid naive, as in not having opioids in their system for the past 30 days. We found that, and so every patient that we consented at least met that criteria. We did not look to see if those patients had, I think the gold standard to look at that would have been to look at PDMP data to see whether our patients had been dispensed opioids for any period prior to consenting them to the study. we did not have access to the prescription drug monitoring database except in a de-identified patient after we had patients considered for the study. So we didn't really have an opportunity to do that. And so trying to find a way to easily ask patients whether they had taken opioids without using any other measure, that's what we decided upon. Another challenge that we have with using EPIC, which would be the other way to do that, is to look and see whether patients have been prescribed opioids in EPIC. We find that we would have missed a large number of patients because most of the opioid prescriptions that happen chronically to our patients in this hospital system actually occur outside of UAMS through other providers. And so a lot of times those prescriptions aren't captured in EPIC.
Okay, with that, we will have to move on, but I'm sure Dr. Gorey would be happy to answer any questions later via email or through a discussion. Thank you so much for sharing your research with us. And our next presenter is Dr. Martin.
All right, well, thank you for allowing me to present. I'm going to present a series of work that we've been doing and culminating in some TRI work. And I also want to, the work that Jonathan Gorey just mentioned was also supported by the TRI in terms of providing the data infrastructure to do that work that worked out this risk from the transition from acute to chronic use. Well, I'm Brad Martin. I'm a pharmacist and a PhD researcher in the Division of Pharmaceutical Evaluation and Policy. I do have some disclosures. I received royalties from company Trestle Tree for the development of an opioid risk prediction tool, and I also received consulting fees from Emax Health for studies unrelated to opioids. A little bit of background, and this was highlighted in the United States. Our opioid use peaked around 2012, 2013. Back then, it was recognized that we were starting to first use the words opioid epidemic. And there was a lot of national attention. In 2016, the CDC published guidelines outlining the use. Other guidelines have been developed. And we've been decreasing opioid use since, but it's not low. If you look at the most recent data that I was able to find, we're still there's about 60 prescriptions filled for every 100 persons. But despite that decrease in opioid use, we are still seeing increases in opioid overdoses, although the last year looks like it has flattened off. Where we were kind of ramped up in prescription opioid use was the first wave. Heroin use kind of started taking on when we hit the peak in 2012. When we start mitigating prescription opioid use, we see an increase in heroin. And then over the last half decade, we're seeing more overdoses due to synthetic opioids, mostly fentanyl. Now, there's been some concerns about this pressure to reduce opioid use. There's been some very recent and some emerging evidence that when you look at persons that are on chronic opioids and you disrupt that therapy, and you can disrupt this therapy. This first study looked at the variability in opioid dose. And if you looked at doses that went up more than 20 or down more than 20%, it was shown to be a risk factor, both whether you went up or down, to increase overdose. And counterintuitively, discontinuing chronic opioid use was associated with an increased risk of death from overdose. And it was greatest for those that were on opioids longest. So here the kind of theory is that, you know, if some have chronic opioids, if you cut them off, then they switch over to illicit uses with that. So this kind of got us thinking about, well, what can happen when we interrupt chronic opioid therapy? And this work was received support from NIDA in the form of an R36. Corey Hayes was the PI on this. I was his major professor, and these were his PhD dissertation studies. And really what we did is we compared everybody to like people that maintain chronic opioid dose or maintain chronic opioid use. And we compared to built a comparison group for people that increased their dose. So we have a series of studies I'm going to show you that looked at this comparison between those that kind of maintain dose and those that increase dose. I think you, and as many as you are kind of imagining what the results will be, probably not going to be too many surprises here. Then we built a group of people that discontinued chronic opioids and compared those to those that maintain chronic opioid use. And then what I'm not going to show you today, just to try to get in the 12 minutes, compared those that were using opioids intermittently, but not in a chronic fashion with this. And this was in a VA group of people that had chronic opioid therapy, they had chronic pain, that were non-cancer, and they were regular VA users with that. And we were looking at really two things. One, the main efficacy endpoint of using opioids for the most part is analgesic control. So we looked at pain levels. And then we also looked for opioid adverse effects and substance use disorders. So we were looking at overdose, accidents, injuries, violence with that. Our first study was published earlier this year in the Journal of Pain. And this gets looking at comparing those that increase their opioid dose compared to those that maintain dose. And we can see that those that maintain the dose, we see decreases in pain over the following periods. And it's higher for those that increase their opioid dose. But I'm going to tell you these differences are fairly small, even though they're statistically significant. The average pain score at day 91 to 180 in their chronic, in the period at which they escalated the dose, was 4.5 versus 4.3. And this is really not considered, though statistically significant, not really considered a clinically important difference. So conclusion is escalating doses really don't seem to increase pain control. And I will say the sample size here was just under 20,000 subjects. This is a really large sample. Now when we pivot to looking at the potential adverse effects of opioids, and what we find is that when we look at our composite measure of adverse outcomes, when you escalate doses, about a 30% increase in risk. A lot of that was driven by an increase in injuries. When we look at opioid-related adverse outcomes, and these are mostly opioid overdoses, in our primary analysis, we don't see a significant increase, but dose escalators in some of our alternative ways of looking at the data showed an increased risk. We see an increase in self-inflicted injuries, and violence-related injuries we really didn't see effect there. But overall, increasing an opioid dose increases the potential risk for many of these outcomes that we looked at. When we looked at the risk of substance use disorders, escalating opioid doses was associated with increases in our composite measure of substance use disorders. Whether or not you're likely to pick up an opioid use disorder, and it was about a 50% increase in the risk of that on a relative term. When we looked at other drugs of abuse, we see an increase in risk and also an increased risk of alcohol use disorder. So escalating opioid doses, and these are people, both of them maintain chronic use over their period, but when you increase opioid doses, it seems to increase risk, and we really don't see a benefit in terms of better analgesic control, in terms of self-reported pain measures. Now looking at whether or not somebody discontinued opioid use with this. And then whether or not people discontinued opioid use in this bottom graph, looking at people that switched to intermittent opioid use. For people that switched to intermittent opioid use, we see decreases in pain score, and those that maintain chronic use fairly stable. But here again, very small differences in this. This is looking at those compared to intermittent use. Here again, those that transitioned to intermittent use had a little bit better pain control than the others. When we look at adverse outcomes for those that discontinued opioid use, we see, and this is different than some of the other findings, is that discontinuing opioid use was associated with a lower risk of getting an opioid use disorder. Whether or not you were going to have a composite measure of adverse outcome, which is largely driven by a reduction in wounds and injuries with that. So here, the upshot of this work is that if we discontinue opioid use, we're really not seeing in these chronic pain patients a worsening of pain. And we are seeing that some of the risks are lowered with that. Now, this work has limitations. One is we have arbitrary rules that define increases in dose. We define an increase in dose as an increase in an average of 20% of the average morphine MME or milligrams of morphine equivalent in that. This was an observational study. This was not a randomized controlled trial. So there's going to be a traditional confounding with this. Now, we tried to control for confounding. We had about 50 variables, including changes in pain score, mental health comorbidities, but also we have time-dependent confounding because we could imagine, oh, 2 minutes left, so I better hurry on. So I'm going to get to the TRI-based work. So to address some of those limitations, instead of coming up with these arbitrary groups, we use group-based trajectory models to identify clusters of subjects and how their opioid use trajectories change over time. We did this in 2 samples, one in the VA sample that I just presented, and then also one that's been TRI supported through the Southeast Shrine, which represents a collaboration from UAB and UMS. What we find is that there are 9 different patterns of opioid use in a very large sample. We had almost 500,000 subjects that started chronic opioid use. We followed them over a period of 2 years. I will tell you about half the subjects maintained chronic use in the VA, whether at a high level or at a still chronic level, but not as high a level. About 10 or 15% will ultimately discontinue. Then others will transition from different periods of opioid use, and some will increase over this. When we look at this in smaller samples, here's the UMS data, we find 4 trajectories. Much like the one before, we have a trajectory that's based on chronic use, where we have people that maintain chronic use. One of the things that's different in this data, we follow people for up to 3.5 years. We have a group that gradually discontinues. We have a group that rapidly discontinues, like we observed in the VA. And then we have a group that maintains some level of subchronic opioid use over time. Now, one of the things when you do these studies and you do it in 2 samples, you hope that you get findings that collaborate each other or corroborate each other. And we find nearly the identical trajectories when we look at this in UAB. I'm going to switch to acknowledgements. I mentioned Corey Hayes, who kind of led the work on the VA work, on the Southeast Shrine collaborations. Stefan Cortez is the PI there. Trey Spencer and Shrab Saeed did a lot of the work on this. I want to thank you for the opportunity to present. I'll be happy to take questions.
Thank you, Dr. Martin. We appreciate your presentation. And next on deck is Dr. Larson Pryor.
So I'm going to talk to you about the complex relationship between chronic opioid use and sleep, which is my primary area of interest. And I want to start out with my acknowledgements of the very lovely, the most spectacular team ever helping out with this study as my collaborators: Meredith Adicut, Nahit Kumar, Michael Mancini, Allison Olivetto, Aaron Kemp, and Debbie Hodges, without whom we wouldn't have had a study. So I'm going to start with a very brief introduction. This will probably be repeated by many people throughout the course of this. So we know that opioid overdose deaths in the US more than quadrupled between 1999 and 2015, as Brad just pointed out. And the potential for misuse complicates the medical use of these drugs. The data I'm presenting here by Han et al. Was derived from the 2015 National Survey on Drug Use and Health. There were 51,000 respondents, and the analysis was done to estimate the one-year prevalence of prescription opioid misuse in the US, and it's important to note that this is all by self-report. The authors broke them into 3 age cohorts. You can see that there are differences between age cohorts, with the most misuse reported in the younger age cohorts. Basically, overall, 12.5% of adults sampled in this study were using prescription opioids misused them, and of that group, 16.7% reported opioid use disorders. The study was also interested in the motivations people indicated were the reasons for misuse, and that is what this table is pointing out. And I want to note that the majority of people reported that misuse, and even misuse related to opioid use disorders, was the most common motivation. However, in keeping with my interest and hypothesis, help with sleep was another one. And it was included in both groups at approximately the same level. And this is very interesting, particularly because we know that opioid use and misuse is associated with disturbed sleep. So whether you're using prescription opioid analgesics or you are misusing them, you are disrupting your sleep, not improving it. This has been reported over and over. I'm reporting here from a 2005 study, which looked at a very small sample, 7 healthy adults, but over a long period of time, 3 nights. And this requires that these individuals report to a sleep laboratory, be instrumented, sleep overnight, and then have their sleep scored by professionals. So sleep occurs in stages. We have early light sleep, which is represented here in the dark gray and black bars as stage 1 and stage 2 sleep. Slow wave sleep is your learning sleep. This is this period of sleep in which we consolidate new learning. And REM sleep is your dreaming sleep, also associated with improved learning and memory. And you notice that in the baseline group and in the placebo group, the percentages of time spent in light sleep, slow wave sleep, and REM sleep are roughly similar. But in those who are on opioids, and these were healthy, normal adults, none of them were chronically on an opioid. This was an acute IV administration. You see that you have a much increased time spent in very light sleep, a drastic reduction in slow wave sleep, and a reduction in REM sleep as well. What could this possibly mean in relation to the development of misuse or opioid use disorders over time? Well, we know that sleep disruption impacts mood and cognitive function. We also know that in opioid use disorders in particular, we have disruptions commonly in mood and in cognitive function. So we decided to look at the impact of buprenorphine-assisted treatment on sleep, and one of the reasons for this is that methadone-assisted treatment is known to disrupt sleep. We're looking at the effect on sleep, mood, and cognition in opioid use disorder patients who are treatment seeking. We recruited subjects from the CAST clinic. I'll explain that in just a moment. They had to have been in treatment for at least 2 weeks to be eligible for the study. We have a wide range over which people were actually involved, and I'll show you that in just a minute. We collected data at 2 to 3 time points. The first was at baseline, where informed consent was obtained, and we also got self-reported sleep quality, depression ratings, and anxiety ratings. At that point, we gave every individual an actigraph, which is a mechanism for objective scoring of their activity levels and their sleep. And they were also provided with a 7-day sleep diary. They were asked to wear the actigraph consistently over 7 days, and then to return it and the sleep diary to the lab at their 2-month visit. So approximately 2 months after the baseline visit, we collected intermediate data. We collected our self-report in depression, anxiety, and sleep quality. We did not provide an actigraph unless this was end of study. And in 7 cases, this was the last time point we collected. Where it was possible, we collected again 2 months later at 4 months, which was our originally determined end of study date. And at that point, patients were again provided with an actigraph and asked to use 7 days worth of actigraphy and a sleep diary to be returned to the laboratory. Everybody complied with that. We got all our actigraphs back, which was good. We collected data in 14 subjects. The age distribution was well within our range, our recruitment range of 21 to 50 years. We recruited from the PRI Center for Addiction Services and Treatments buprenorphine clinic. I should explain that the CAST program consists of group and individual therapy sessions and routine monitoring for substance abuse, and progression over 4 phases is determined by regular attendance at therapy sessions and negative drug screens. This indicates the number of study visits we had for our subjects. So 8 subjects provided data over 3 study periods, 5 provided over 2, and 1 provided only 1 data point, that is at baseline. And you can see that there's a wide variability in the number of days that these individuals had participated in the buprenorphine clinic at the time of study entry. And where did my, there it goes. We also collected, as I said, several self-report and cognitive measures. So the one that we're going to spend a lot of time on is the Pittsburgh Sleep Quality Index. This is a validated subjective scale, so it's self-report that assesses perceived sleep quality. We received information on the Patient Health Questionnaire 9, PHQ-9, which is a self-assessment measure of mood or depression. And we collected information on generalized anxiety. We also collected cognitive information on essentially the ability to delay gratification using delayed discounting, dimensional change card sort test that is a measure of executive function, in particular adaptation to new environmental stimuli, a flanker task which measures attention, a list sorting task which measures short-term memory, and of course we collected our actigraphy. For your information, and I will put this up, I have normative values for our 3 primary mood and sleep data sets. So we'll talk about that a little more in the next few slides. So I would like to introduce you a little bit to what actigraphy actually measures. Our gold standard for measuring sleep is polysomnography in a sleep clinic or in a laboratory, but measured as you would in a sleep clinic. However, the results of many, many studies have compared actigraphy to PSG, and they support a strong relationship with over 85% correlation in measures of objective measures of sleep between the 2 methods. So for many individuals, actigraphy is the best way to actually measure sleep across time. Polysomnography is done over 1 time period, that is 1 night of sleep. So in the studies looking at the applicability of actigraphy to sleep studies, at least 5 consecutive nights of data are required if you wish to reliably estimate sleep efficiency, which is a measure of the amount of time you spend asleep versus the amount of time you spend simply being in bed trying to be asleep. So you're looking here at an actigraph of a pretty good sleeper. Here in blue, you're seeing the periods of time when this person is active. Notice at about 11 a.m., the person reports that they go to bed. They are clearly not asleep at that time. They're just as active as they were during the day. They fall asleep. And the period of time from between them going to bed and them falling to sleep is a measure of something we call sleep onset latency. How long does it take you to fall asleep once you get to bed? You're looking here at the green period. This is the total sleep time, how much time they're spending asleep. And of course, here's our time in bed. This little guy here is they woke up in the middle. This measures wake after sleep onset. The more wake after sleep onset, the worse the sleep. So you're looking at an individual here who has lots of wake after sleep onset. In fact, there was no sleep whatsoever. Their perceived sleep quality was very, very poor, and their sleep efficiency was also very poor. And here's another good sleeper. So what we found is that overall our participants reported worse sleep quality from baseline to the end of study, but that variability was driven by a few subjects with very, very strong differences between baseline self-perceived sleep and the time measured at either 2 or 4 months. So in red, you're looking at the people who endorsed worsened sleep, and in blue, those who endorsed better sleep. We expected everybody's sleep to get better, so this was a little bit of a surprise. Wake after sleep onset, an objective measure, and our sleep efficiency almost universally improved across our subjects. We also looked at the relationship and the absolute value of mood. We found, as we might expect, that as perceived sleep quality worsened, the endorsement of more depression and more anxiety also increased. And although we found no changes in short-term memory or attention, we did see a significant negative correlation between sleep quality and executive function, that is, that set shifting task, which suggests that these individuals are having more difficulty adapting to novel situations. And this was also true for the delayed discounting task. And I'd like to point out here in a trajectory analysis that Yasiram Ramandala and Corey Hayes are doing and have submitted as a proposal to the NIH. We noticed that pain, dorsalgia is back pain, nonspecific pain, and sleep disorders all contribute to major depressive disorder, which is also a contribution to the opioid-related disorders that they were interested in studying. And in our study, 8 of our 14 subjects did endorse pain more than 3 times per week as disruptive to their sleep. So we found that, as expected, the majority of participants endorsed poor sleep quality at baseline, but we were surprised to discover that that worsened over time in general. Nonetheless, the objective measures of sleep were consistently improved. Thus, there appears to be a disconnect between the objective measures of sleep quality and the effects perceived by treatment-engaged adult participants. In keeping with a large literature, individuals exhibiting poor self-reported sleep quality had higher levels of depression and anxiety and poor cognitive function. So the relationship between poor sleep, reduced mood, and reduced levels of cognitive control are likely to contribute to impulse control deficits in this population. And finally, there's a clear relationship between pain, sleep, and the development of opioid use problems that should be better explored relative to mood and cognitive dysfunction in this population. So thank you very much for your attention.
Next on our list is Dr. Hayes. So Dr. Hayes, feel free to take over.
Well, today, thanks for inviting me today. I really appreciate the ability to come and talk. What I'm going to talk about today is a pilot project through TRI, which looked at integrating the Arkansas Prescription Drug Monitoring Program data with the Arkansas All-Payer Claims Database. And so as I think Dr. Mock mentioned on the front end about us, I'm Corey Hayes. I'm an assistant professor in the Department of Psychiatry, as well as a secondary appointment in biomedical informatics. And I'm also split with the VA. I'm a research health scientist over there in the Center for Mental Health and Outcomes Research. So here in just a minute, I'll talk about why we would even think about integrating these 2 data sets and why that becomes important. So just to acknowledge funding, this was funded by TRI through their pilot awards, and the information for that funding is there. Okay, to give you some background of these 2 data sets to kind of lead us to why we would even integrate these 2, the APCD, or the Arkansas All-Payer Claims Database, is a data set that holds data from most insurers in the state. So this includes Medicare, Medicaid, commercial payers such as your Blue Cross Blue Shield, third-party administrators or self-funded, Arkansas State Employee Benefits Division, so that includes us within UAMS, as well as the Workers' Compensation group in Arkansas. And it has many different claims types within it. So this is going to capture, the APCD will capture medical claims that come through to be paid by your insurer. It also gives you information on eligibility. So how long did you have insurance? What type of insurance did you have? As well as demographic information. What was your gender, race? It also has dental records. So if you have dental insurance and went to the dentist for various different things, we'll capture those records as well. Pharmacy records are included in this, and what we've mostly honed on in for this small project is the pharmacy records that you received throughout the state, as well as workers' compensation records. Now the PDMP is a little bit different. This is a data source that was originally created, so PDMP stands for the Prescription Drug Monitoring Program. The original creation of this data source was for providers to, whether you're the prescribing provider, dispensing provider, to go and be able to pull up where you've gotten other controlled substances. So if you are receiving opioids from Dr. X down the street, Dr. Y over here can pull that up and look and see, what did you get, when did you get it, and how much did you get from Dr. Z. So it's an ability to kind of look at what the patient is getting as far as controlled substances. So therefore, it's only pharmacy records for controlled substances. This mostly includes opioids, benzos, benzodiazepines, stimulants, and other controlleds such as Lyrica. This is a very interesting data source because it includes pharmacy records paid for not only by your insurance, but also via cash. And so we do know that this becomes an issue sometimes when we do have patients who are doctor shopping, what we would call doctor shopping, in that they're going from one doctor to another to try to get additional opioids or any other controlled substance. Sometimes their insurance will be able to pick up on that because they are submitting those, the pharmacy is submitting those claims to their insurance. And so the patient may elect, I just want to pay for it on cash so that it doesn't go on my insurance, because it would, in most cases, probably get a rejection if you just got a fill for opioids yesterday. So the project goals for this particular integration was to create a nearly comprehensive picture of controlled substance use in Arkansas. And by that, I mean prescription controlled substance use. So at this point, once we integrate these two data sources, we now have the records of all Arkansans and what controlled substances they received. The second project goal for this was to assess the importance of including PDMP data in our analyses of commercially insured individuals. And so this is kind of what I'm going to focus in on, and it's a little bit of a nerdy methodological aspect of using big data, but it becomes really important. So like when Dr. Martin was talking about how we've looked at trajectories for patients who are commercially insured or within the VA, it becomes really important to be able to estimate exactly how much, despite there being a commercially insured individual, how much exposure to opioids are we missing because we are only looking at their paid claims data from commercial insurance. So that was one of the second goals of this project, was to evaluate how important it is to include this PDMP data. So the pilot project had three aims. One was to integrate the Arkansas PDMP and APCD data, which was no light feat in and of itself. Second was to assess the degree of concordance of opioid prescriptions and patients between the data sources. And third was to quantify the risk profiles of patients within the Arkansas APCD data, whether using APCD data alone versus the merged data. So what that means is when we have this patient identified through the Arkansas All-Payer Claims database, if we integrate their PDMP data, do they appear to be an acute opioid user with just one data source, but actually in reality a chronic opioid user? Or are they a high-risk user when we incorporate both data sources and we include all of those prescription records that may have not been captured by their insurance? So for today, we only have a short period of time. I'm just going to talk about the first two aims for this particular quick talk. So aim one, I'll give you some information on this linkage. So the way that we did this was through a de-identified mechanism that's fairly complicated. But what we did is the ACI, who houses and administers the Arkansas All-Payer Claims database, has a hashing algorithm in which they place for their patients. And so what it does is it creates this de-identified number, let's say, for the patient whose last name is this, whose gender is this, and whose birth date is this. And so then it creates and turns Corey Hayes into number 1234A or something like that. So we had to do the same thing with the PDMP data, and then we could drop the identifiers of the PDMP data and have the two linked, because now we could have the same hashing algorithm for Corey Hayes applied to the PDMP data as we did to the APCD data. So I am now 1234A in both data sets without any name or other identifiers. And this required us to sit at the Department of Health for, I think, a total of 10 hours. I think we spent from 12 p.m. till 10 p.m. one evening letting this run as we sat there and watched it, because it had identifiers at the time that the hashing was being created, so it was a very sensitive aspect to the process. And then, lucky for us here at UAMS, if you don't know, the Arkansas Bioscience Institute has a copy of the all-payer claims database administered and housed in the Department of Biomedical Informatics. This is a great resource for any faculty member within UAMS to be able to use. And so then we had the two data sources now housed over on the servers in Biomedical Informatics de-identified. And we got all this done by July, August of 19. Okay, the next is aimed to looking at the concordance of opioid patients, really. I should have put patients there instead of prescriptions. And one of the ways that you do this is generally, in just thinking about how to do this, is you can use a method in which we use for evaluating tests. So we're in a current opioid epidemic, yes, but also a COVID pandemic. And so if you think about COVID and how you would assess, say, the nasal swab, you might compare the nasal swab tests to what's considered the gold standard right now of the PCR. And so the way that you would do this is you would have the patients classified as either having the disorder, let's say COVID, or not having COVID, based off of the PCR test. And so that's what you would put at the top here. Thank you. And then you would compare to your test, so your nasal swab tests, in which the test result was positive or the test result was negative. And so it creates a nice 2x2 table in which you can evaluate the test that you're looking at. And there are 4 specific test calculations that go with this. So sensitivity is if a person has the disease, has COVID, how often will they test positive? So in our case, changing this over to looking at opioids, if a patient has the disease, if they're actually an opioid user as per the PDMP, let's say, how often will the test be positive, or how often will they show up as an opioid user in claims data? The same for specificity. If you do not have the disease, if you're not an opioid user in the PDMP, will you show up as a non-opioid user in claims data or APCD? And the positive predictive value is if you test positive, let's say you're positive within an APCD, what is the probability that the patient actually is an opioid user in the PDMP? And then vice versa with negative predictive value. If you're negative within the APCD, are you also negative within the PDMP? And so this is what this looks like as we set it up in a 2x2 table. On the top, we put the PDMP data, and on the side, we put the APCD Medicare data. So in actuality, when we talk about the APCD, it is actually broken up into 2 separate data sets, those with claims data, so like on the Blue Cross Blue Shield plans, and those in Medicare. They're actually separate here. Medicaid goes in the all-payer claims database. And then the third arm is the Arkansas Prescription Drug Monitoring Program data. So that's what you see here in the orange. We ended up with, when we applied our cleaning criteria, we had about 587,000 patients in APCD and Medicare data, and we had about 1.2 million patients in the PDMP records. So when we did our 2x2 table, we had around 200 5,000 patients. So the basis of our 2x2 table is this number here, this 587,000 patients who are in the combined APCD and Medicare. So we had about 205,000 who were in both, and you can see this, I'm running out of time. But the overall message here is that when you're looking at a commercially insured patient population, the sensitivity, specificity, positive predictive value, and negative predictive value are all pretty high. So among patients in Arkansas with continuous Medicare pharmacy coverage, APCD and Medicare captures 91.83% of opioid users. So this is a pretty good thing in the fact that we are doing a pretty good job with claims data and capturing opioid users. So acknowledgements, I have several co-investigators here. Thank God for the data analysts, Xiaotong and specifically, and then we did have other contributors, ACI, Department of Health, that really helped move this along.
Thank you, Dr. Hayes. Our next speaker is Dr. McCool. So we will turn the floor over to Dr. McCool, who can share his slides and do his presentation.
I think our title is covered here, but it's about the development of and implementation of a tool that would help us to assess chronic pain and manage it in adult sickle cell patients. I would like first to thank TRI for supporting this study and for all the logistics and the help that they have provided us with, but also the co-investigators, Colin Montgomery, Leanne Wilson, Lindsay Dyer, Jacob Painter, Sarah Council, and Stella Bowers, and our consultants, Dr. Sarah Harrington and Suzanne Sixenti from Children's Hospital. The problem that we are facing with sickle cell disease survivors is at this point becoming extremely important to address. You know, sickle cell disease is a result of one mutation in the hemoglobin gene, leading to the polymerization of hemoglobin inside the red cells and clustering of these red cells in the microcirculation, leading to ischemia. So patients over time, they start initially having episodes of acute pain, and little by little, these episodes lead to destruction of the organs. And as a result of that, the patients would suffer from chronic pain. And it's intuitive perhaps to ask me, why don't you treat the cause? Treating the cause turned out not to be that easy. And at this point, we have modern treatments like bone marrow transplant and gene therapy that are making headways, but they're not yet ready for use in everybody. And there is a window of time where you can use these modalities and cure the disease, and therefore prevent the episodes of pain and organ destruction. However, we are now 2020, and the patients that we are seeing in our adult clinic, all of them are older than 18, and these modalities did not exist at the time when they would have been eligible for it at younger age. Hence, we have now large number of patients who reach adult age, and I want to give you some statistics. We have about 100,000 living sickle cell disease patients in the United States. In Arkansas, we have about 1,000 adults and about 400 to 500 children. The care has reached such a point now that we are, even without being able to cure the disease, but improving management by blood transfusion and other means to allow those patients to reach adulthood. And that's where the problems of chronic pain start. Indeed, they start earlier, but they continue during adulthood. And now we have many patients who are in their 40s, 50s, 60s, and so on. So this is the problem that we are facing. The patients are, because they're living longer, they become afflicted with that chronic pain, and opioid had become really the main weapon to fight this pain. Practically, there is no patient in our clinic. We have 350 adult patients so far in our clinic, and we hope that we'll be able to reach all the way everybody who is in Arkansas, although it turned out to be extremely difficult task. However, out of the 350, we have a handful, I would say, couple dozens of patients who are not on opioids. So the majority of the patients, unfortunately, are. And we realized the impact of this on them as well as on their ability to function in society. Hence, this project really was trying to tackle this issue, to understand the underpinning of what underlies the continuation of the use of opioid in our patients that can be fixed other than the disease itself. And hence, the goals of our project were three. First, we wanted to screen for sickle cell patients that are at risk for developing high-dose daily opioid use via risk assessment based on their current opioid use and mental health screening, and develop a tool to optimize opioid use while maintaining and or decreasing pain scores and maintaining or increasing quality of life, and evaluate the effectiveness and feasibility of this protocol. So the methods, we gathered a team of people who are involved in the care of these patients. We did not have a pain specialist, and listening to my colleagues here, I feel that I missed the boat. I should have invited all of you guys. And I'm thinking I had now jotted down several proposals to many of you, so please respond to my emails if you get them, because I truly need your help. So nevertheless, I was the adult hematologist. We had a pediatric hematologist, Dr. Sixenti, and we had the APN, the social worker, the palliative care physician, Dr. Harrington, a pharmacist, two pharmacists actually. One of them is the statistician of this study, and another researcher that lent a lot of expertise to the study. So we met initially, we tried to design based on our understanding of the mechanism of pain and chronic pain in particular, and the factors that contribute to magnifying or augmenting that pain or the perception of pain, and therefore the use of steroids. And we established an algorithm that I will shortly present to you to evaluate all these aspects and try to fix what we could fix and see what we can get. And our assumption is that we will be able to definitely get many patients off of steroids or decrease their morphine equivalent daily dose, MEDD. When we submitted the protocol to the IRB, we were told that this is a quality improvement protocol and we did not need consent. So we only asked the patients if, you know, we are trying to improve your care, you want to participate and answer these questions, and that's how we did it. I think you have to always know exactly what you wish for, and I wish we have submitted it as a research protocol, because not only would that have cut, in my opinion, in terms of the time that is needed now to try to publish these data, but also it would have helped us structure it in as a research project rather than as a quality improvement project. Nevertheless, the data are very interesting, and you will see that. Our population is the adult patients with sickle cell disease in our clinic, and we collected the data in our electronic medical records the way that they came in that electronic medical records. And we had 2 points for analysis, pre and post and individual level assessment of the clinical decision tool. And this is the clinical decision tool that we have established after discussion. I hope that you can read it, but we start from the beginning. As you can see, we evaluate everybody if they have complications. If they do have, for example, aseptic necrosis of the hip, the treatment is not opioid, the treatment is to do hip replacement. So we send them to see a specialist. So we had the list of all the chronic conditions that can lead to pain and can be fixed by one specialist or another. And I identified those folks whenever we answered yes and send them to the appropriate specialist. If they had no complications, then we evaluated them for depression and anxiety. Look how concordant our finding also here with the one of my colleagues' presentation about the role of anxiety and depression and sleep deprivation and what have you in pain, and either augmentation of pain or perception of pain. So for those who answered yes to our survey, they ended up having optimization of their management or initiation of treatment and re-evaluation in 4 to 6 weeks. Those who said no, we went to the only treatment that has proven to be effective in decreasing the frequency and intensity of pain crises in patients with sickle cell disease, that is cheap and available and approved actually by the FDA, which is hydroxyurea. So those who were on hydroxyurea, we optimized their dose. Those who were not, we started them on hydroxyurea. And we started working on the impact of these approaches on the dose of opioid. So first of all, we said, let's try to maximize the non-opioid interventions before we touch the opioids. And once we have reached a point where the patients felt comfortable with that, we started working on the opioid side. Sometimes we needed to raise the dose because after everything we have done, it appeared that the pain was not well controlled. And sometimes we were able to go down on the dose or stop it. And the dates, we started our baseline period to recruit the patients to this study between November 2018 and April 2019. And the clinical decision tool period was from May 2019 to October 2019. We wanted to have at least 6 months to be able to work with these folks, but no less than 1 month or 30 days between the two assessments. So inclusion criteria, they have to have a visit in the baseline period. The patient must be on opioids at baseline, and we did not have a problem finding those patients. And also a visit to the sickle cell clinic in the clinical decision tool period. And they should not have less than 30 days between the two visits. The primary outcome was the change in MEDD between baseline and follow-up to achieve similar to better level of pain control. Other outcomes, here they were whether, if they had prescribing at baseline one of these drugs and what happened after the implementation of the instrument. Opioids, all of them certainly, hydroxyurea, SSRI, SNRI, tricyclic antidepressants, anticonvulsants, and non-steroidals, anti-inflammatory drugs. And this is our population. We enrolled 165 patients to this study. Their mean age, as you expect, was 34 plus minus 11.5. So that means we had patients who were in their late 40s and headed toward their 50s. We had 60% of our patients female. As it's expected, most of those patients, all of those patients in our country here are African American. Their weight was average, and their types of visits were clustered depending on whether it was with the nurse by herself, or with the physician as well. And we had patients who came to us not necessarily getting their treatment by our providers. So we had 28 patients, 17% of our cohort getting their main treatment outside, and they come to us for planning for their future treatments and helping guiding their treatments and providing with some other workup that is not available locally. And these are our results. For the patients who were at baseline on opioids, 165, 100% of the patients, that was an inclusion criterion. After the implementing and applying the clinical decision tool, 151 only were still on opioids, which means that we have decreased the number of opioid users by 8.5%, and that was statistically significant. However, when we looked at the remaining patients on steroids, believe it or not, the MEDD for those patients who stayed on steroid did not change. But we are running a different analysis to include the other ones that are zero now, and we will see that would shift definitely toward lower MEDD, but we excluded them. The reason why we did that, we wanted to identify a group of patients who was really on the edge, getting not too much steroids, and see what is so specific, because all those who quit using steroids were not getting a lot of steroids. And that's an important point. The number of acute crises was lower, and their use of steroids was not high. So if we could bring those folks, the other ones, to that range, would we be able to get them off steroids? That was kind of one of the ideas that we had. However, the important thing for us in our eyes of the implementation of and the use of this tool is the astronomical number of patients who were not on hydroxyurea and got to be on hydroxyurea, which is the main treatment that we can use now to limit the end organ damage. We went from 21% to 57%, and that was highly statistically significant. We treated many patients for their depression, as you can see from the use of SSRI, SNRI. The tricyclic antidepressant, we don't use them for antidepression per se. We use them as sleeping aids sometimes and to help with pain. So the difference was not statistically significant. Anticonvulsants like gabapentin and others were also increased significantly, and that was good. And the NSAIDs as well, NSAIDs use has doubled. So in summary, 8.5% of the patients were able to get off of opioids, and that was statistically significant. Median use of opioids for the remaining patients was not statistically significantly different, and large increases were seen in prescribing at the clinical tool visit for hydroxyurea, antidepressants, anticonvulsants, and non-steroidal anti-inflammatory drugs. Pain and quality of life data collection was incomplete, unfortunately, and as I told you, that was probably the tax that we paid to not adhering to a strict research protocol. And however, we are analyzing the data to see if we can sort out something that would help us guide future treatment and future studies. Our future directions actually will focus on publishing the current data after IRB approval. So we are submitting a new protocol to allow us to use retrospectively these data, and applying for an extramural grant to support a multi-center validation study. Longer follow-up, we think that the 6-month follow-up was short, especially the effect of hydroxyurea on chronic changes of the bones. The main site of pain in those patients might be delayed, might take 12 months or probably even 18. So increasing the follow-up would probably result in better outcome in terms of decreasing the opioid dose or weaning all these patients altogether of opioids. We did not want to look at that as an aim of the study, but we're looking at the use of long versus short-acting opioids. And we want to study specifically the characteristics of those who were able to stop the opioids. What was so special about their disease, about their daily opioid dose use, and so on. And we want to introduce now, we have a lot of novel treatments, and we want to see if we can introduce those treatments to our patients and see the impact on opioid use. And finally, we will use research tools to collect pain and quality of life data for the next study. And in that regard, I'm really here intimidated, to tell the truth, by the wonderful work that my colleagues have done in that area. And I feel that our shortcomings hopefully will be compensated by their willingness to collaborate with us and embark on the next phase of this project. For my acknowledgement, I would like to thank all the patients and their families for their participation. I would like to thank TRI for their invaluable funding and logistical support, and the team members who made it possible to design and conduct the study. And I will be happy to take any questions.
Thank you, Dr. McCool. We're gonna move right along because we're just a minute or two behind. So thank you for your presentation. We really appreciate it. And we're gonna move over to Dr. Nesmith. So Dr. Nesmith, I'll allow you to share your screen and take over.
Okay, so I'm Claire Nesmith. I am a pediatrician in the neonatal intensive care unit. Our group works at Children's Hospital and at University. People don't know that we have a 60-bed intensive care unit here at UAMS. We, as everybody has said, and so I'm not going to go into all that, you know, I've seen this great uptick. I've been practicing for 20 years, and in the last 10, we've been treating a lot of babies with withdrawal. And it greatly increases their length of stay, and there's not a lot of objective data on that. So that was what my project was. Can you go to the next slide? Okay, so the rationale was that the management of NOWS is neonatal opioid withdrawal syndrome. It also has been called neonatal abstinence syndrome, but we have to change the acronyms periodically to confuse everyone. So NOWS is kind of the groovy thing to call it now. And it's non-standardized, it's symptom-based. You use the Finnegan. Nobody has a real consistent way to approach that. A long period of observation for NOWS in the hospital is obviously expensive. It's done in the intensive care unit. And we wanted to answer the question if infant exposure or their drug concentration could be associated with clinical outcomes. Next slide. So our hypothesis was that the drug and metabolite profiles of buprenorphine exposed neonates would correlate with their outcomes. And so that was what we were proposing would be, we would find out. Our aims were to measure the parents, the moms, and the metabolite concentrations of buprenorphine in neonates, to examine the relationships of the neonatal drug concentration to clinical covariates, and to compare the neonatal drug and metabolite concentrations to Finnegan scoring. I'm just going to talk about the first two aims. We haven't gotten to the third one yet. So our methods, we collected 3 samples. One was at the time of birth, which was taken from the cord blood. So that was basically the same level that would have been in the mom. And we collected that from moms who were on buprenorphine. And we had planned on doing that for either buprenorphine or methadone, but the PRI is obviously where most of these patients are seen, and they've really moved to buprenorphine for moms who are pregnant. Well, all moms are pregnant, but anyway, because the babies tend to withdraw less and the length of stay has been shown to be less. And so we're not seeing very many people come in now that are pregnant that are on methadone. The samples were obtained again from cord blood. We collected at 24 hours because every baby gets a newborn screen at 24 hours. So that's why we didn't have to stick them again. Pediatricians are really cognizant of pain and sticking babies. And then the third sample was at the time that they needed morphine for their withdrawal symptoms or prior to their discharge home, which is usually, we watch these kids for at least 72 hours. Sometimes some places are watching them for as long as 5 days. Then the samples were analyzed for buprenorphine and its primary metabolite, more buprenorphine, using liquid chromatography. And that was done at a lab at Children's by Jeff Moran. So if you look at this, and these are kind of small, but buprenorphine has 3 major metabolites, but the major one is processed through the cytochrome P450 to norbuprenorphine. And so that's the metabolite that we focused on. There's been some other interesting research done on the other metabolites, but our focus for this was with norbuprenorphine because it's the major one. We recruited subjects at their presentation to labor and delivery, which is a little tricky to consent. But the best place that we did was from psychiatry's weekly therapy sessions for the moms that are on buprenorphine that are in the opioid addiction program. And we, as pediatricians, about 2 years ago, started going to those therapy sessions at least once a month to just prepare the moms for what might happen. And this is the things that you can do. And, just to kind of answer a lot of questions for them. And so that was a great place to recruit. And the study orders were implemented in EPIC. So just brief about buprenorphine. It's a partial opioid agonist for the mu receptor. Its maximal effects are less than those of heroin and methadone. It has a super high affinity for receptors and competes with morphine. And so sometimes when you start babies on morphine for withdrawal, you have to start with a bigger dose. There have been places that have advocated to use buprenorphine in the babies, but the formulation right now is not such, and it also has a really long half-life. So we stuck with our morphine protocol, but you do have to sometimes start with a larger dose because buprenorphine has such high affinity for the mu receptor. So in our interim analysis, we enrolled 14 mother-infant pairs. All the moms were on buprenorphine, so we didn't have anybody on methadone. The maternal dose had a really pretty significant range, but it was 0.21 milligrams per kilogram. All the infants were Caucasian and non-Hispanic. That has kind of been our population. It's changing a little bit as I think everything does, but that was the ones that we had. We had 6 females and 8 males. The median birth weight was right at the 50th percentile, which is 3.09 kilograms. That's just almost exactly on the line. And 6 of the infants required morphine for neonatal neonatal opioid withdrawal syndrome. So what we found, which was really interesting, is that norbuprenorphine was more commonly detected than buprenorphine. So even in the cord blood, these babies, cytochrome P450 was already revved up and going and metabolizing buprenorphine to norbuprenorphine. The analysis of norbup indicated a median range of elimination half-life of 54 hours, but there was a huge range on the half-life. It was from 19.6 to 96.8 hours. And infants without detectable buprenorphine were more likely to require morphine treatment than those that we detected buprenorphine in their cord blood. Let's see, is it going to go to the next slide? So this is just showing you that the ones that the orange line is the ones that did not require morphine, and the green line are the ones that did require morphine. You can see that norbuprenorphine did fall over that time, and that there wasn't a whole lot of difference between the median for the 2 different groups. So a lot of questions. One, and we have gotten, from this grant, we have gotten some Embry money, and we are going to partner with Louisville, Kentucky, and continue to enroll to try to further understand if quantifiable buprenorphine in the cord blood can predict the infants that will not develop NOWS. So if they have buprenorphine in their cord blood, can we say, okay, we don't need to keep this baby, but maybe 2 days, or this baby can go home with mom. Another thing that we want to fulfill that third aim of comparing the drug metabolite concentrations to the Finnegan scoring. And we're hoping to include some residents and med students in that. And then we want to examine the relationship of maternal dose and treatment duration to infant concentrations. So it would be, what we're hoping to do, that next slide I think will kind of explain this better, is we would love to get a sample from mom prenatally, and then have the cord blood, and then maybe on the kids that withdraw and end up staying longer, to see more consistent half-life evaluation, and kind of see how that correlates with their Finnegan scores, and the ones, what do the levels look like compared to how long the baby had to be in the hospital. And then the other thing that's going to be different about the second phase is that we're going to make a phone call after discharge to kind of quiz the moms on, do they exhibit any withdrawal symptoms at home, after they went home. And so that'll be another helpful thing to find out, because we are keeping them only 72 hours if they don't show any symptoms right now. So that'll be helpful to know. That's what we should be doing. I don't know where I'm on time, but I'll any questions?
This is Lisa Brentz. What was said about around slide 10 or 11? Could you go back to that point about the relationship between, yeah, right there, infants without detectable bupe were more likely to require morphine treatment than those with detectable bupe. So was there any relationship with norbuprenorphine and how likely they were to require morphine?
Well, we had 14 babies, and so I don't know, we couldn't really establish a relationship, but it was interesting that the babies that still had buprenorphine in their cord blood
were less likely
to withdraw or to show those symptoms. So that, again, is going to be an interesting phone call. We have had, I know we've had in the last year and a half, 2 babies readmitted to Children's Hospital for withdrawal. But of all the babies that we treat, that's a pretty low number. So that was really interesting. It's interesting to wonder how long the mom's been on buprenorphine, you know, and what her dosage is, and if that has anything to do with whether the baby has more or less when they're born. So there's a lot of unanswered questions there.
So this is Linda Larson Pryor, and I think I have 2 questions.
Okay.
So the first, actually, thank you, Lisa, for pointing us towards this slide. You noticed that your kinetic analysis of the norbuprenorphine indicated a very wide range for half-life.
Right.
Did you look at the relationship of the half-life for clearance to this indication of whether morphine was required in the infants?
We did not. We did not.
So it might be kind of interesting to see if the clearance rate had an effect on that.
Yeah.
And then secondly, I think it's your next slide where you had the graphic of this data. Yeah, slide 12, right? That's the graphic. Yeah. I'm really struck by there doesn't seem to be any particular pattern in this, although in some babies it does look like there's a much larger, in the ones that needed morphine, there's a much steeper decline.
On 2 of those, there sure is.
But otherwise, it's really difficult to see that there's any particular difference. Did you come to the conclusion of these infants needed more just because there are more of them in this condition? I mean, I'm just kind of interested in your conclusion that those who showed no detectable buprenorphine were those most commonly on who required morphine.
Yeah, that's a trend. Again, only 14 babies. So I don't know. I don't know what that means. I know that the median, you know, for the 2 groups is not really that different. But
thank you.
Yeah, I don't know if Dr. James has anything she wants to add to that. But.
Yeah, I agree with your conclusion. The graph is, although there were 2 infants who seemed to have a more dramatic drop there, overall there were not major differences between those 2 groups, between those that required morphine and those that did not, and in terms of the elimination half-life. I think, Lisa, your earlier question on buprenorphine, there was much overall for the population, norbupe was detected much more commonly than bupe, so we were not able to do as much on the bupe on the pharmacokinetic analysis. I think that was your question.
Okay, thank you so much, Dr. Nesmith. We have reached the end. Thank you guys for attending.